Welcome back to The Breakdown. This is the season 3 finale. No Demogorgons, no plot twists, just me, a little champagne to celebrate, and a look back at some of my favorite clips from season 3. I learned so much this year, and I thought I'd give you the cliff notes of some of the moments that stayed with me. We kicked off the season by tackling one of everyone's favorite topics, insurance. I talked with Kelly Huber, our business services director, about the basics of insurance. In this clip, Kelly tells us what patients need to know before seeing a specialist and why it matters. Take a listen. So here at Rothman, our physicians are considered specialists in the insurance world. So a specialist is treated differently from your primary care physician or your internal medicine physician. Can you tell us what we need to know about when somebody comes to see a specialist versus seeing their regular primary care? What's different from the patient
everything.
side? Everything.
Everything. Yeah. So first and foremost, on the insurance card, it's going to have multiple copays. It's going to say a PCP copay is X amount. A specialist copay is X amount. Your specialist copay is always going to be more than your primary care copay. So as the patients are coming in or ahead of time when we're checking eligibility and benefits, we're going to look for that specialist copay amount. So we collect the right amount. A referral. If you have an HMO plan, your primary care physician has to put in a referral for you to see a specialist. The difference there with the primary care is when you see that your primary care physician, you don't need a referral, but to come to a specialist, you do.
Right.
So you're going to want to make sure I have an appointment at Rothman on January 17th. On January 13th or 14th, I need to make sure that referral was sent over from my primary care doc.
Right.
If it was not, you will be responsible for that bill. And we do not like to see patients getting bills of
Get
that
turned away.
magnitude.
Right. Yeah.
Right. And then any testing. So if you're seeing a specialist and they're order any imaging or physical therapy or any of those types of procedures, you're going to need that referral again. So you're going to hear us use that word a lot today.
Right. Okay. Yeah. I just want to point out that I was wearing my Eagles green for that first show as a good luck charm and also to put some good energy out to our birds. And boy, did that work, because we all know who won the Super Bowl this year. Maybe we should ask Patrick Mahomes who won the Super Bowl. Get me Patrick Mahomes on the phone over there. And get me Prescott while I'm waiting for him. We'll ask them who won the Super Bowl. Our Eagles did. Super Bowl champs. Okay, next up, episode 2, where we covered telemedicine. I sat down with a familiar guest, my husband, Alex Vaccaro, the Dr. Alex Vaccaro, El Presidente of Rothman Orthopaedics, longtime spine surgeon, and someone who uses telemedicine every week. Listen as we talk about some of the rules around telemedicine, and keep in mind that the rules are ever changing. If you're considering a virtual visit, check directly with your insurance plan for the most up-to-date guidelines.
You're always in touch. So I think it's improved care. So what we have to do is we have to always petition Congress to continue to allow audio and visual telemedicine, because let me just explain the rules to you.
Yes.
Before COVID, you couldn't do telemedicine. And if you did telemedicine through CMS, which is Medicare, Medicaid, you would have to leave your house and go to a sanctioned facility, just like you and I are doing a podcast, and do it there.
You as the physician, so you had to be in a medical.
The patient had to go. So why? Well, listen. What does telemedicine allow? It's great patient care, but it allows unfettered, unlimited access, and that increases the cost of care.
Right.
So we're studying it ever since it increases the cost. If anyone could do a telemedicine, so Congress made it more difficult. You had to go to a special sanctioned place. Now they got rid of that for COVID. And now they're trying to bring it back. Also, I have people around the world calling in for telemedicine. If you don't have a license in the state of Montana, I can't do a telemedicine with you. So Congress is looking at that, saying a Pennsylvania license may be applicable for telemedicine in other states. So remember, you have to do it by your license, what states you're allowed to be in.
Right.
Now, outside. So I see people from all around the world, telemedicine, but I can't do telemedicines with people in certain states in America because I don't have a medical license.
Right. So I do want to point that out for the listeners that if you are trying to schedule a virtual visit, you have to check in with your insurance. And even if you call Rothman, our team, our access team, our billing team, they'll be able to walk you through what you can and can't do as far as visits with your insurance plan. And so each state has their own protocol. Each insurance plan has their own protocol. So you just have to make sure that you're checking out to make sure that you are covered. So like you said, if you're not licensed in a certain state and that's where that patient lives, then you may not be able to treat that patient.
Unless your state medical board has an agreement with that state. Now, I
Right.
think there's 38 states that have a consortium. Now, I have a medical license in 6 states. So those are the 6 states I do telemedicine in
Right.
all the time,
And I
which is
think
great.
that's important for the listeners to know that, they may just assume that because we have offices in Pennsylvania and New Jersey and Florida, that those are the only states that our physicians are licensed in, but that's not the case. So which states are you licensed in?
New Jersey, New York, Pennsylvania, Delaware, Florida, California, and of course Hawaii, because everyone needs a medical
You're
license in
treating in
Hawaii.
Hawaii every week.
We need a medical license in
Oh my
Hawaii.
gosh. Next was episode 3. This was our most watched show of the season. And for good reason. We talked about Ozempic and its role in orthopedics. I sat down with Dr. David Kugelman, a joint replacement surgeon and researcher here at Rothman. At this point in the show, Dr. Kugelman explains how Ozempic should be used properly, how it has the potential to reduce infection rates, and why there's even a focus to lose weight before joint replacement surgery. Listen in, this is so interesting. So you're a fan, I take it, of Ozempic. Are you a fan of the drug?
I am a fan in certain situations.
Okay.
So it's not for everyone, and it needs
Right.
to be taken correctly. And what I say by that, there's side effects, right?
Yeah.
Anything we do is going to have some side effects, and Ozempic's a drug that does not come without them. The biggest side effects, you got to take it appropriately. So if you just take Ozempic and eat junk food when you are hungry, or take Ozempic
Mm,
and don't eat at all, you actually might have worse outcomes following certain
really?
procedures
Yeah.
because your nutrition status is not optimized. So what I tell patients, I recommend working in a multidisciplinary approach with this, between the orthopedic provider, the primary care physician, and a
Hmm.
nutritionist. And I'm a firm believer that Ozempic can lead to good outcomes for joint replacement surgeries or other orthopedic procedures only if it's done right. So when I say done right, there needs to be a high protein, high fiber diet. We need to have the proper nutrients in our body. So all our vitamins and minerals we learn about when we're very young in grade school, that still needs to be coming in. And that's where we kind of work together with different physicians and, other providers like nutritionists to make
Yeah.
that happen.
So you mentioned about decreasing the infection rate. How does that specifically decrease the infection rate? Is it because of the weight loss or is it because of the medication itself? How does that
Yeah.
work?
So, it's kind of a cause and effect. Our theories are it's pretty much both. So we do know it's been well established. Increased BMI, specifically BMI over 35, 40, it will lead to infections and worse outcomes
Really?
following
Okay.
orthopedic procedures.
Got it.
So, so the reason for that is, we have a lot of adipose tissue. There's bigger wounds,
Hmm.
less potential for healing. So obesity is really detrimental with orthopedic procedures, and
Interesting.
Ozempic obviously will help a person lose weight. Furthermore, sugar, glucose, that's all inflammatory.
Right.
So we hear about, sometimes gluten's inflammatory and all these different aspects of our diet that can cause inflammation in our body. And inflammation can also lead to worse outcomes and infections. So Ozempic, it could level our sugar throughout the day. And especially in diabetics, if your sugar is not controlled and you have a knee replacement, there's a very good chance that you will get infected.
Wow.
So Ozempic's a part of that for the diabetic optimization to make sure your A1C is at a good level, that your sugars are well managed
Right.
post-operatively. So it's probably a mixture of those two, the inflammatory aspect and the weight loss.
And I have one more clip to share from this episode. Honestly, it was so hard to narrow this one down because there was a ton of great information. But this next clip I found to be critical, especially if you're on Ozempic and are about to have a surgical procedure. Listen.
So let's recap that. Ozempic delays gastric emptying, which is the rate at which food leaves the stomach. This delay in digestion can pose a risk before surgery because it can lead to a higher risk of nausea, vomiting, or aspiration while under anesthesia. An empty stomach is critical for a safe surgical procedure, and delayed gastric emptying could interfere with this requirement. It's crucial that you inform your healthcare provider if you're taking Ozempic or a similar medication before undergoing any type of surgery.
All right, let's keep this party going. Episode 4 focused on opioid reform. I interviewed Dr. Ozempic, one of Rothman's hand and wrist surgeons who also serves as the president of Rothman's Opioid Foundation. We had a fascinating conversation about how Rothman is helping to change the course of the opioid epidemic. The research that Dr. Ilias and his team are doing and the action steps that they're taking are making a positive difference in saving lives. Before we play the clip, I want to share some of the more recent stats. So according to provisional CDC data, overdose deaths involving opioids dropped from about 83,000 in 2023 to roughly 55,000 in 2024. This is a significant decrease year over year, and our hope is that this decrease in deaths is a trend that will continue because 55,000 lives lost in a single year is still far too many. In this clip, Dr. Ilias talks about a couple of the factors that contributed to the opioid crisis. Let's listen in. I remember when I had my wisdom teeth out, that I got like this full bottle that could have lasted me a year maybe. I don't know. I didn't take any of it. I took a couple Tylenol. I was fine, but I had this full bottle of Percocets,
That's a very common story. My own experience, having had some things done, the same experience.
Yeah.
I think it was based on, first of all, I don't think it was malicious or malevolent.
Right,
That's
right.
So firstly, I think it was just not being aware of the risks of prescribing, overprescribing, right? Making sure that patients' pain, an individual doctor's patient's pains are well maintained. There was some structural dynamics. It's very hard to, before that was called e-prescribing, you had to get a paper prescription to get the medication. So this is something we had to deal with constantly up until the law changed in 18, where you had to get a paper prescription. So you, as a doctor, you wanted to make sure that you gave enough, because if they ran out, they can't get a refill easily.
Right.
You have to go find a doctor to get that, right? And so you overprescribe for the sake of the patient. But what that led to is two big things. One is when patients are given more, there is a tendency to use more, right? And this is just a normal human trait. We've studied this as well, that the more you give, more people take. The less you give, the less people take. So the bigger the bottle, the more they'll take. The more you take, the more you get sensitized. So there is an untoward consequence of overprescribing, right? So that was one of the major issues. And the other issue was that in terms of the number of opioids that you're getting, is that as you get more, you become more sensitized to it, and you need more. So
you need more, right?
What we realize is that when we can tailor the amount that we're giving, is more effective. So one of the first things we do when we're studying and say, like, how much do people need? And that data was really amazing. And so what we realize is we don't want to give too much so they don't take too much. And the second part of it, I didn't complete my prior thought, was this concept of diversion. So if your doctor gave you, say, 30 pills for your wisdom teeth, you use 2, right? Fine. There's 28 pills sitting in your medicine cabinet, right? So anyone in your sphere of influence, anyone that comes into your house has access to it. Could be spouse, could be kids, could be relatives, could be friends. In my own home, I have 3 teenagers now, almost not teenagers. There's kids in and out of the house all the time. So they're in my sphere of influence. They can open up a medicine cabinet and access it. This is the concept of what's called diversion. So just extrapolate you getting 28 more pills than you need to all of the surgeries, all of the procedures in a day being done in one town, one state, one country. We're just disseminating all of these opioids into the community. So people take more when they get more, and even if they don't use it, it's available for abuse called diversion.
Oh my gosh. Episode 5 focused on the balancing act of female physicians. I chatted with the lovely Dr. Megan Bishop and the lovely Dr. Danielle Ponzio, 2 amazing orthopedic surgeons who also go by Mom. We talked about everything from operating room schedules to bedtime routines, and yes, even Bluey. We all love Bluey. If you know, you know. They manage it all with such incredible skill, but it got me thinking, if they can balance so much, why are there still so few female orthopedic surgeons? Let's hear what they had to say, and I'm going to take a sip. So I just read this the other day that orthopedic surgery is currently the least female-dominant medical specialty in the United States. I didn't realize that it's the least, that there's no other specialty with less females than orthopedic surgery. Why is that? Why do you guys think that's the case?
I think there's a lot of reasons, but again, there's data too to support this. But I think there's not very many female mentors in orthopedics.
Right.
And so going through medical school and training years, you might not meet people that are doing that to show you that, hey, there's a path here that you could do that. And then also there's a sort of a perception that you need a lot of physical strength. And it's not completely wrong. I do think, it's probably a reason why Megan and I are athletes and we gravitated towards.
Interesting. Yeah, because I did read that the physical demands of the specialty is a reason why it's like, so explain that. What are the physical demands? Yeah, how does that work?
You want to speak to it?
Well, I mean, for Danielle is the joint replacement surgeon, so that's like definite physical demands. Like on large hip replacements, I mean, that's certainly like a struggle. But taking care of knees, shoulders, things like that, it's a lot of positioning of the leg, and patients are of all different sizes.
Yeah.
You can have patients you're taking care of, especially like if you're taking care of a professional athlete. Those people are generally,
bodies,
they have much larger makeups, but particularly for knee scopes, you have to actually like balance the leg on your body to be able to scope the knee, position it in certain ways. So you certainly have to find techniques that work for you. Certainly, it's a little bit more skill and management of your teams if you don't have like strength that a lot of guys have versus But there's always ways to be able to do every procedure. If you're a female, brute strength isn't the only way to be able to do something. So, you employ your teams, you employ different strategies and techniques. And I actually had a patient recently tell me this week that he had no pain after surgery, and it was his 3rd knee scope, and he said, "I must have delicate hands." So I said, "There you go."
Episode 6 focused on the headaches of prior authorizations. I was joined by Dr. Dan Davis, shoulder and elbow surgeon here at Rothman, to talk about the process from both the patient and physician perspective. Just to give a little bit of background, some insurances, not all, but many, require patients to get a prior authorization for certain medical studies, procedures, and even surgery. Here is when I ask the question that I have often wondered about. Take a listen. So sort of the reason behind it is twofold. One, cost, so that the insurance companies could contain costs so that there's not all of these studies just being done, or whatever that aren't needed, but also for patient care too, that a patient is, and this is where I kind of want to go down, and I might be jumping the gun here, but how would an insurance company know what's best for the patient? Who's on the other side of the authorization?
It's a good question, and it's really dependent on, I think, the insurance company and what kind of system they use for prior authorization, which is another frustrating part of it, is that different insurance companies have different systems.
Okay.
And I think some do work well. The people who, to answer the question directly, it's many times physicians that are on the other side of that.
Okay.
So there are physicians that are either directly employed by insurance companies or employed by these clearinghouses, which insurance companies will then contract with to go through that process. Some definitely work better than others. I think many are getting better, some through required legislation, which I know we'll get to in a little bit. But others just by wanting to do a better job and wanting to help the system.
Yeah.
So there are some where, and I don't find this as much anymore, but this definitely used to be the way 5-10 years ago, where you're trying to schedule a patient for an orthopedic procedure and you're talking to a family medicine doctor on a peer-to-peer phone call, or you're having your case reviewed by, a retired cardiologist. Well, they know a lot about their field, but they might not know as much about orthopedics.
Right.
And so generally if it ever gets to the point of a peer-to-peer, and a peer-to-peer is an actual phone call between me, the treating physician, and the medical reviewer physician who has reviewed the case. So that's why it's peer-to-peer.
Got it.
And in those times when you had like a non-orthopedic surgeon that you're discussing the case with, they by and large always approved it because they were like, listen, you know more about this than I do. But depending on their clearinghouse rules, who they work for, some companies were very strict and said, well, if you didn't go through physical therapy and do this, then no, we're still going to deny it.
Right.
Those are definitely cases that would drive a lot of frustration for orthopedic surgeons because, they're not there seeing the patients.
Right.
As I alluded to, however, I think there are some companies that are doing a better job of that. They're having orthopedic surgeons review orthopedic surgeon cases. They're having, even down to the subspecialty of orthopedic surgeons, they're having like a shoulder specialist review shoulder cases, a spine specialist review spine cases. They're having cardiologists review cardiac cases. And they also are using those physicians to help build their guidelines, which they then go to the insurance company and said, these are our guidelines, which we think are appropriate based off the best evidence that our group of physicians have come up with. And then the insurance companies can say, okay, we're good with your protocols. And I think that will help as more of that develops in the future in limiting the frustration that the treating physician has with it, because hopefully that will limit the times that cases are denied or going to peer-to-peer, which is really where the frustration comes from.
Cut. Let's say that again. Okay, so who's on the other side of that prior authorization? As Dr. Davis said, it's often a physician. However, it can be a nurse or a reviewer who is using standardized criteria to make the call. They're ultimately deciding if the requested service meets the guidelines of the insurance company. Rounding out the season was our AI episode where we talked about, you guessed it, artificial intelligence. I had a great conversation with Dr. Michael Rivlin, hand and wrist surgeon and AI enthusiast, about how AI is making its way into orthopedic care. Here's a clip.
So again, we are just scratching the surface,
Right.
but there are opportunities that are currently existing that we decide not to do. Because
Okay.
again, it's like any tool, you need the right thing for
Yeah.
that right tool. If you let the tool go by itself, it will make errors.
Yes.
We are not ready, in my opinion, for a hospital to run by itself on AI. There are so many reasons why I don't think it's the right idea yet.
Yeah.
And we can talk about it a little bit more.
Wonderful.
We do use AI, and you may not even know that you're using AI when
Yeah.
you're doing AI. For example, in healthcare, when you have an MRI done, there's a lot of work that the AI does. So they make your quality of images better, so it's more accurate, more precise, and we can make better decisions.
Wow.
AI as a tool right now is mainly used as decision making.
Okay.
So it helps us figure out the right answer by cleaning up the data and making sure that we get clean information so we can get clean answers to that.
Okay.
Eventually, and this is where eventually maybe AI will be operating on probably not me. Eventually, the AI or the computers will be able to interact with us. But for now, we're interacting with AI just to get us better.
Gotcha.
It becomes more interesting when something actually can be autonomous and control itself to do whatever we want.
Mm-hmm.
And let's go back to basics. So
Yeah.
I can teach the AI, let's start simple, in my house one day to take out the trash. The trash is always the same place.
Yeah.
It always goes in the same place.
Yeah.
What AI needs to know is that the trash can is always going to be blue for recycle and black for regular.
Yeah.
And it will find it in my backyard even if I put it a little bit different place.
Yeah.
It will learn how the trash can looks, right?
Gotcha.
The same thing translates to medicine. For now, we are doing very simple things. and then we can train the AI and tell it very specific things to make life or death decisions or anything that probably should not be done by a computer, because that becomes a scary novel.
Oh my gosh, yeah.
So control is a lot more important as we explore AI, but AI will be a tool.
And that's a wrap on season 3. Thank you for listening and joining me on this journey. There are a gazillion podcasts out there, so I'm so grateful that you took the time to listen to ours. I wish each of you a wonderful, happy, healthy new year filled with lots of love and happy times. And as I close every show, stay healthy, stay strong, and take charge of your health. I'm Lauren, and you've been listening and watching The Breakdown. Salud. This episode of The Breakdown is presented solely for educational and informational purposes. I'm not a doctor, although I could play one on TV if they would let me. The Breakdown is not intended to diagnose, treat, or provide personalized healthcare recommendations. So, if you've got a bone to pick about your health, be sure to consult with your physician or a licensed medical professional, or give us a call at Rothman, and we'd be happy to steer you in the right direction. Gabish? We'll see you next time.